I think the session will be, we will have three speakers, one for children, one for adolescents and young adults, and one for the older ALL patients. And which is important to realize is that the disease is not the same across the different age. So there's some biological subset of the disease that are very different. The distribution of the subset is very different in children as compared to the older adults. So that's maybe one of the reasons why even if we can deliver the same treatment to older patients as compared to younger or to children, which is not the case because older adults cannot tolerate very intensive chemotherapy. But even in that case, we will not produce the same result because the disease is not the same. And in the older age, there are many more resistance subgroup of the disease. I mean, subset resistance to standard chemo. So we are currently at the limit of the use and result associated with standard chemotherapy, and we need new drugs. And that's the good thing is that we do have these drugs now, and the next challenge is to move these drugs from the relapsed refractory setting to the frontline setting. I would say that pediatrician, the most important problem at the present time is how to treat those children who relapse for the disease. So the most important issue is to treat relapsed refractory disease. And in the adult setting, the most important issue is to treat higher risk patients. Those patients with ALL with a higher risk of relapse frontline. So it's not exactly the same issues and the same way to deal with these issues. For pediatricians, the problem is how to what is the optimal treatment for a relapsed refractory disease. And we have the same issue, but frontline, but basically that's the same issue. And we will use the same tools and the same new drugs to address these two issues. And that's the introduction of immunotherapy to treat relapsed refractory disease in the children, to treat frontline disease in the adult, and how this immunotherapies, including CAR T cells, but also bispecific and antibody drug conjugates, could allow us to reduce again the incidence of transplantation, because transplantation is quite aggressive procedures associated with long-term complication and problems. And so this is the most important question for me at the present time, is how these new drugs will allow to improve the results and the survival of these high-risk patients, relapse refractory, mostly in children, higher patient or subset at higher risk of relapse, mostly in adults. I think the area, it will be addressed by Oliver Ottman from Cardiff University, the area of Philadelphia chromosome positive ALL. It's quite exciting because in that subgroup, which is very rare in children, but very frequent after 40, 45 years of age, in that subset, we have new immunotherapies, but we also have more and more potent tyrosine kinase inhibitors to treat these patients. So the next step, and the dream, is to treat this patient only with immunotherapy and tyrosine kinase inhibitors. No chemotherapy, no stem cell transplantation. And very interesting preliminary results on the basis of that combinations, for instance, blinatumomab plus ponatinib, are coming up, and that's really exciting for the next future.